empowerment is incredibly important, and I do support things like the Epsilon apps, and I support things like the SUDEP checklist. These things are helpful. I mean, pilots need to go through a checklist before they fly us. So we shouldn't be too embarrassed to need a checklist to go through to remind ourselves of all the things that are supposed to be asked.
You know when you can feel the warmth of somebody even through the screen? Well, that's what I felt when talking to Mike Kerr for this week's podcast. Professor Mike Kerr is a globally recognised award-winning neuropsychiatrist based in Cardiff in Wales, who specialises in improving the lives of people who live with epilepsy, learning difficulties and mental health issues, which often all come in together. Mike talks about his extensive experience and the value of caring for and improving the lives of his patients. Stay tuned to learn more, and if you haven't already, and if you want to, then do subscribe to the channel and hit that bell for notifications. Together, let us all improve outreach, epilepsy awareness, understanding and research. So hi there, Mike. Thank you for joining us. Could you please tell everybody a bit about yourself?
Well, Torie, thank you very much for inviting me on to this famous programme of yours, Epilepsy Sparks. Well, I'm Mike Kerr. I'm what's called Professor Emeritus, which means I've a semi-retired professor from Cardiff University and also Swansea University in Wales. And I specialise in epilepsy and have done for many years, especially people with learning disability and epilepsy, and issues around people who have psychological distress and epilepsy. So, over the years of my career, I've mainly focused on a combination of clinical work. So I've had tens of thousands of consultations with families and people with disability and epilepsy, and also, a lot of research around understanding epilepsy, understanding the mental health in epilepsy, and also around the healthcare for people with learning disabilities.
When you say learning disabilities, how do you measure learning disability or intellectual disability?
Okay, well, it's a combination of things, but it changes all the time. And but essentially, it's a combination really about adaptive functioning, how the person can cope with living, associated with IQ scores, which are very, very rarely used these days as a measure. We hope not to have to reach doing actual IQ scores. So it's often about a person's learning ability, their adaptive ability to care for themselves and their risk. In individual services, the actual measurement may become, quite a moot point, because it may be a very fine borderline that you get support for learning disability rather than not support, and somewhat like the diagnosis of autism or something. So it can be very difficult, but in my particular world, I will probably not get too worried about the measurement and diagnosis. If I see someone, I'll see them. But of course, the person's abilities and their understanding and their capacity to understand is central to care delivery.
And tell us what got you into this work, because I do know for a fact, and we've spoken about this before, and statistics say it all, that we need more people in professions such as yours. So what enticed you into this?
Okay, well, it's probably quite a long story, but very quickly, I trained at Bristol University, and then I went up to York to train as a general practitioner, and I was sure I would be a general practitioner. But during that training, I worked with a fantastic psychiatrist called Dr. Susan Shaw, who showed me that psychiatry could be more clear than people perhaps consider it to be, and you could make sensible, clear decisions in psychiatry, and it was doable, but also quite medical, and I've always liked the medical side of things. So I came down to Cardiff to follow a particular person I wanted to train with, and when I worked for somebody who worked in learning disability, a chap called Professor Fraser, who was fantastic, and he collected a collection of young people around him who were all following him and committed to work for people with disability and close down institutions and try and help people with intellectual disability. So I carried on in that, and then I suddenly realised that a lot of people had epilepsy, and because I trained as a GP, I knew that I knew absolutely nothing about epilepsy, and it worried me a lot that I had to actually manage people not knowing anything about them. So I went to work with the professor of epilepsy, late Professor Alan Richards in Cardiff, and I worked doing clinics with him and being taught by him for the rest of my training. So that made me an epilepsy doctor just by chance. So I don't think there was any any moment when I became someone interested in this. I think I had a general interest in inequalities, in interesting people who were more complicated and a bit more fascinating as they were complicated, and lived with other people and had complex lives around them. So that maybe enticed me into this. And then epilepsy just caught me, as I think it catches quite a lot of people, because the discussions and both the medicine and the psychiatry and the social side of it are all super complicated. And I think you can, if you get it right, help people.
It's like the word complicated. It just makes me think of a load of spaghetti, and it's all intertwined, almost like a messy brain, isn't it? And it's like how you can't just address one thing. If a person has learning disabilities, they're, as you're saying, so likely to have epilepsy or other issues, you kind of got to look at all sides of the string of the pasta.
Well,
right?
I'm not sure how far I can follow this through. I'm not to Professor Van Tam, but I would say that you've got to be careful, because if you don't watch it, you'll never eat the pasta. So you actually have to start addressing bits of it and see how it unravels. And that's something which, my role is about trying to communicate which bits we should start having a go at. Because some of those things are about the person and their lives and their personality, which a doctor can't alter in the clinic, and you have to be very realistic about. But I can certainly look at diagnosis, and I can certainly look at communication, and I can certainly look at treating epilepsy and supporting risk and those sorts of things. A problem with such complicated situations is that there's a chance for paralysis of treatment, and I think that does happen quite often, that people get told there's nothing more you can do, it's too complicated. When I generally don't think I've met anybody where there isn't at least something to discuss, no matter how many years they've had epilepsy for, and how many, because there's always something in people's lives, and epilepsy always changes.
Do you know what? I really like that last piece you just said, epilepsy always changes. People tend to think, and many clinicians too, I think, that you're diagnosed with epilepsy, say you're 10, 20 years old, it's going to be the same forever. And your needs, as a result of the epilepsy or comorbidities, will never change, but that is not the case.
No, it's not. And also, of course, knowledge has changed. So when you offer long-term support, we weren't perhaps advising about bone health and enzyme inhibitors in 1995. Maybe we should have been, but I worked for a professor of pharmacology, and it wasn't an issue then. And we weren't necessarily talking about SUDEP, only just thinking about it. We weren't talking about psychiatric comorbidity in the same way. We were getting out of an era where there was too much association between epilepsy and psychiatry, and it was people not that long ago had been in institutions because of it. So, we were moving into another world, and that had to be redefined, and we had to make sure that we weren't recreating that concept and putting it in a way that was, more appropriate for the person. So things have changed all the time, and one of the things I've been lucky enough is that, there's families I've looked after for. I look back on the notes, and it's 1991 or 1992 when I first saw them, and you see it isn't just that the families, people, we all get older, and the parents get older, and the person gets older, and we change. So, you're always happy to be thinking about something new occurring and a new angle, and looking at someone differently when you see them. I think that's really important. Status quo. You don't want to just maintain status quo if you can, unless it's very, very good. What
would you say, before I call, we're nattering a little bit about SUDEP. How important would you say that is to bring up and explain to families?
Everybody needs SUDEP explained, in my opinion, right from first presentation of seizure, so theoretically before diagnosis. Because of risk. I don't think that's a contentious statement. I think we need to talk about risk and open it, and it's absolutely crucial, because I think we look at it for a long time, as we see from the experience of families who have been and partners who've been sadly lost their loved ones. That the pain of feeling that the risk wasn't communicated was appalling, and the pain of feeling that you could have mitigated against that risk and you didn't because you didn't know about it was even more appalling. So of course we have to do it for that reason, but I think it's much more than that. It's an honest communication with people about trying to explain why we do things. So understandably, people think giving these quite powerful drugs is a big thing to do, which it is. And sometimes I think we forget to tell people why we're giving them. And this is one of the reasons, is, it's to stop the seizures, and the seizures are dangerous. in a range of ways. So, I think that's, that communication of why we just do our simple management is really important. You don't want to, make it, overwhelmingly, an oppressive message, because it can be a positive message. A lot of people will reduce their SUDEP risk, but people need to be aware of it, need to be aware that when it changes, or if epilepsy changes, you may need to revisit why you're doing things to reduce the risk. So I think it's extremely important. I mean, it's got to be part of a package, and it's got to be done in a sensitive way, and and personalised, which is very important, and probably not just by somebody like me in a clinic, but in my situation by my team, people I work with in the community team, who will have different forms of contact with people and different environments in which to talk, and also to make sure, I think, the message is understood. There's a lot of messaging for people with a very big diagnosis, and you could quite easily, I think, miss stuff out, and you could quite easily not read leaflets. So I think it's important to keep on going and keep on talking about it.
Yeah, I think especially as it's one of those things so many of us, if not the majority, don't really want to know about. You want to know what your risk is, but it's not like you want to hear this thing which can initially be rather frightening. So I agree with what you're saying, like tell the person or the family pretty much straight away so that it can start to sink in. And then also people can't say that they haven't been told about it and how to minimise the risk.
Well, also so you can start mitigating against your risk, not just of SUDEP, but of epilepsy-related deaths, such as
indeed.
And it's no point taking the lottery of a few more events before you communicate that message. So
yeah.
It is very important, and if it has an effect on people, then we should try and support them with that effect.
Exactly, because that's another thing to do with epilepsy and learning disabilities, isn't it? It's not just one or two things. And actually, I was thinking along the lines of communication. How do you cope, for instance, not cope, or how do you manage a situation when, say, a patient may be non-verbal, or there may be, say, language issues of other types? How do you manage that?
Well, I think that's obviously very common in epilepsy and learning disability, intellectual disability, because the severity of epilepsy associates with the severity of the intellectual impact on the person, and so often we see a lot of people who are complexly comorbid with epilepsy and lots of other conditions. Well, there is absolutely no way that I'm any more able to do that communication than anybody else. So, but first of all, you need to know that, and obviously what you want to do is make sure you are communicating at the maximum and supporting that person in the maximum way possible. So, hopefully there'll be others around them, family members, carers, and then my person might have a communication book, might have a communication aid. So you have to talk about how to do this. The person is central. So you have to work with the person, but of course at some stage the person can't speak and doesn't understand the discussions. You will have to work for those who work with them. So it's a case of working out, the classical complaints, quite rightly, are about, the person with disability who is actually able to hear and speak, not being talked to, and this the carer is spoken to, and not including people. And we have to absolutely make sure we avoid that. I mean, it is a bit dependent on carers, supporting and pointing out that, this is the communication style, and people should have how does somebody communicate? So. And sometimes, of course, it takes a lot of messages, but I don't think it's just people with learning disability who need a lot of messages. I need a lot of messages before I learn something. And it's not a unique thing to think that in one visit you could take everything on board.
Right, especially it can be pretty overwhelming, especially upon diagnosis, I think, or it's a rather sensitive topic if it affects like a lot of your life, or the majority of your life, I guess, with many of your patients, and a lot of a huge part of the lives, I think, of family and carers.
As the word says, they're caring. They feel they want it to go well. They want the person to be. We all want the person to get well. We may have to find a common ground about issues about trying treatments and risk and medication and those sorts of things, or other interventions. But we all want to try and get the same outcome. And the families, have been. They see me. They're 18. They've been under the care often of fantastic paediatricians, and they've had to go through the shock of the United Kingdom's approach to healthcare delivery, whereby you, as a child, your care is delivered a lot by paediatricians, and less by your GP. And then as soon as you become an adult, your GP is absolutely central, but hasn't been necessarily always involved in the discussion around the epilepsy. So it is, and then suddenly you have to go to, every, like the rest of us do, every single different specialty, your chest physician, your heart physician, to get things organised.
It can be so stressful for the patient, thinking, okay, I've got to manage this, and this. And I think that creates extra stress for you guys, because say, for instance, what I've experienced as an adult, and lots of other people I know affected by epilepsy and psychiatric comorbidities, well, they might have a wonderful neurologist or epileptologist who knows a fair bit about the psych issues, but you also need to, assuming that you are able to and have access to a neuropsychiatrist like yourself, that things can be so split up, and can be quite stressful, I think, for families and patients if they do all this themselves.
Well, I think it's very, very stressful because the people aren't always available, of course, and the timescales are enormous, and the acute medical care will be in different environments quite often. You go to different wards, whereas before you went to a paediatric ward, and it's obviously extremely stressful. But it doesn't mean it's bad. Growing up is fantastic for the person with disability, and we see people, change amazingly when they leave their schooling and things. So it isn't bad. It's just a case of finding the way to make it, to support it.
Yeah,
it's a good thing to grow up, but it is a very challenging thing, because it is definitely challenging. You form very, very strong relationships with professionals, and then suddenly you just enter into a new world. And that can't be easy for anybody.
Do you think sometimes it can be almost more stressful for mum and dad or the carer when they've kind of maybe sometimes coddled the person that they love or really wanted to protect them, and then there's change?
Well, I'll put one of my cards on the table, is that of course people can be overprotective, but I really think people are usually appropriately protective. It's just that there's a transition time to support people moving on to something else, because often things have happened because there wasn't the support there. So families have had to do what from the outside looks like excessive support, possibly, but was really a reaction to there being not the appropriate help for them around. So it is hard for the families, because they're the ones, and very frequently the families will be the ones who are expressing the concerns and are describing the epilepsy, waiting for a response from the clinician. And if it isn't what they're used to, it's going to be very stressful, isn't it?
So tell us something positive about your job, and what's made you stick it out for a fair while. Although maybe kind of, like you said before, 1 day a week practice. Although, by the way, everybody, Mike's got a million roles, so look in the text below. It's absolutely nuts. But yeah, sorry, what keeps you going, Mike?
It is, a fantastic, if you like, almost honour to be able to sort of be part of people's lives, and you are, and you're trying to support. Just not that I think that remotely that what I do always supports people, but you are allowed into people's lives, and that it comes with a massive responsibility, and it is fascinating. And I work with, I learn all the time from the families. I mean, I'm hopefully trying to change what I do a lot from the families. It isn't always that unless I change better, I guess, but I do try and change. And you learn so much from experience. Medicine's about experience. It's learning and knowledge, and then what you experience and pattern recognition and these sorts of things. So, it's great to have the consultation. The people with disability themselves are fantastic, and because of that, around them there's often fantastic support workers, and for me in particular, the community team I work with, is great, and they've all got incredibly important roles, and they all do what they do far better than I could do what they do, and how we sort of get that together and work it out for the person is wonderful. And I think I also very much like working with the charities I have worked with in the past and I currently work with. So for a long time I've been with SUDEP Action, and that has changed. Meeting families has just completely changed the way I look at people, I think, so I think it's that keeping you going. Otherwise, I'll just stagnate. So there's a lot of positivity. I mean, you meet great, but you interview a lot of great people. So you meet a lot of great people who are more than admirable, and being lucky enough to meet those sort of people, I think, is good for you.
Oh, totally. And it's you guys that keep me going personally, and I've heard from many patients who listen to the interviews that they are just delighted to hear from the mouth of the experts from the other side of the table. But I think sometimes we struggle that if you go and see whether it's your GP, your neurologist, your neuropsychiatrist, whatever, if you're lucky, you've got 10, 15 minutes. If you're lucky, right? And you don't so often, generalizing, get to understand a bit about the personality of the clinician. And so when they hear about you guys, or hear from you online like this, through podcasts or YouTube, it's really lovely and heartwarming. And I think it enables them to understand a bit more about why you might be rushed and that you're doing a lot of stuff behind the scenes as well. And this certainly applied to myself in the past, probably still does, to be honest, to a degree, is that you don't realise what you guys are doing behind the scenes, all the paperwork, all the training that you never stops in your career, ever. You're constantly learning.
I agree with you. I think a very good example is the fact that, good practice is to ask the same questions every time you meet someone.
Yeah.
But it looks from the other side of the table or the room like the person has forgotten what they asked last time, and like the doctor, and why is he asking all these same questions? But it's actually good practice to make sure you're right, and to make sure the story hasn't changed about the seizures and things, or not every single time, but quite frequently. So you often find this, I think, in families coming out of transition again, where, they've told their story lots of times, it's quite painful. And you need to ask, or for instance, I might have to revisit whether there were problems over the birth or in the first year of life. And now I need to do that because I need to try and diagnose the type of epilepsy, because it's really important for treatment. But it's really painful, and you want to make sure you've communicated why you do things the way you do. So there are two sides to this communication, and I mean, there always will be, and time and services have a big effect. And I think I think this is a particular, challenge from my pure neurology colleagues, because they do tend to have far worse clinics. Psychiatrists tend to have slightly more time, I think. It's a generalization, but I think it's probably relatively true. And neurologists tend to be unbelievably busy. And so it's very, very hard to take on board. No one 20 minutes can cope with that. So you have to have lots of different 20 minutes. And they can happen quite close together and not 2 years apart, unless it's going to take you a long time to get.
What helps you as a clinician in terms of, so my idea that I've said multiple times before is that what I find helps me is to bring along notes to appointments, so that when I forget things, not if but when, it's okay, they're in front of me, and it can be useful to share it with you guys as well. Would you say that's a useful tool for both parties?
Yes, I think whatever suits you, to try and to not forget what was on your shopping list, I think is quite a good idea. We all know that we can forget what's on our shopping list, and that consultation is that time to get across this message. So I suppose the notes can be efficient, but I personally think that it's, quite a lot of clinicians will start by saying, for a new consultation, what are the key things you want to discuss? So you've made sure that you've actually addressed. You probably will have your own, you will have your own gender as a clinician about things you want to discuss in that consultation, but just to make sure you're coming out to address the same issue. So I really support, families as much as possible. We use something called the Glasgow Epilepsy Outcome Scale. It's all been a bit difficult during COVID and communication and things, but this, it's a patient-related outcome measure where there's about 40 questions about various elements of care on epilepsy, which might be concerning you, and I think it's a nice aide-memoire for people. And quite often, really, what matters is what people write in the notes at the bottom about what the big concern is and things. So the more you can do to support that moment of communication, and the vast majority of my patients, if I ask them any questions, will say no. And I'll always say, well, try and get someone to write them down before next time. But that's only natural. I'd be the same. If I have a consultation, I'd probably have to write notes myself before I went to it. It's not an easy environment, is it? And it's sort of, you've been told quite a lot. So to remember your shopping list is not easy. you might just go back to old favourites rather than the one you really wanted to ask about.
Well, especially, I think things like SUDEP, not many people want to actually talk about, but it is something to continue to bring up, I think.
Yes, yeah, well, all sorts of risks and all risks. In disability, you should have your risk assessment done every year, hopefully by your community nurse. So that should have been discussed already, but it should be revisited again. But it isn't just SUDEP, it might be, women on valproic acid, it might be all sorts of things. And then, for every risk you raise and cause concerns, you may take away concerns people have about doing something which is totally safe.
Yeah.
It's because the person, can go because they haven't got photosensitive epilepsy or whatever, so you do take away a lot of, and a lot of people, when we talk about, risk, we actually, we remove risk, we remove restrictions, or we put in, you address that risk by change of medication or rescue medication or something, and that means the person's, life can expand. So you can't do that unless you raise the conversation.
So true. So, like, I spoke to somebody recently who doesn't have learning disabilities, but was scared about flying to the States because of the long distance. And I was like, well, bring that up with your neurologist. Maybe there's something you can take to kind of dope you up a little bit, have a good nap on the aircraft, or I don't give advice or anything, but these are all things that are part of your life. And then like like you were saying, 3% of people who experience very sensitive epilepsy, well, the rest of us are okay. And like, I stopped going to certain clubs. Well, I shouldn't have gone anyway. Gosh, I can't dance. But to these clubs because of flashing lights. But I was fine. But nobody told me I was fine. But I was also having baths, and because I didn't know that I shouldn't be having baths. So there are things that I think will tick and cross, and it empowers the family as well as the individual patient if you can go through these things.
And obviously, I think empowerment is incredibly important, and I do support things like the the Epsilon apps, and I support things like the SUDEP checklist, because these things are helpful. I mean, pilots need to go through a checklist before they fly us, so we shouldn't be too embarrassed to need a checklist to go through to remind ourselves of all the things that are supposed to be asked to do something properly. And we should try and empower our patients. And the simplest way is to make that communication in your clinic such that you can actually be told the things that the person's worrying about, because they could just be gnawing away and they may be not very relevant.
Yes.
Or they may be answerable because it might be something completely different. Where it is challenging is in people who've got multiple illnesses, which a lot of people with intellectual disability do. And, I think quite often, one of the things I have to say is that no one can know the answer to that question, really, because, to do it, you have to ask the person. The person isn't can't respond with language. And so we have to take, we have to look at all the options, set up some hypotheses and work out what the safest hypothesis is to address. And so I suppose the more you do this job, possibly the more you say you don't know. In some circumstances, you don't know, but you might know. And you might know what the most likely option is, and then which is the least dangerous and the least restrictive to that person. So, and that obviously isn't, I think people would love their doctors to say they know their answer, the answer. And you do sometimes, but not always. And that's just because people are very, very, particularly when it comes to, behaviour, these sorts of things, which are often, many things influence the behaviour.
I was speaking to somebody regarding Dravet, and for people who aren't aware, that is a rare type of genetic epilepsy. And they were talking about some kids who smear their feces on the wall and things like this, so their behavioural issues were a real challenge. And then, but I was like, but the rest of the public never hears about that, just generally speaking. I'd never ever heard about that. And I thought, well, why should a family feel, I was led to believe that the family felt ashamed, that they could never talk about this poo scenario or challenge because it's poo. Do you come across things like that very often?
Well, yes, I think a lot of people will have. I suppose probably I wouldn't necessarily remark on that very much unless it was, considered to be an issue at the time. I'd hope the person was getting support from that, from our nursing or behavioural services or something like that. I mean, I think there's a lot of this challenge. Various behaviours are very common in people with intellectual learning disability, because of all sorts of complicated reasons of which, people essentially believe it's communication and not being able to communicate in the way I want, but it's possibly a bit more complicated than that. So, behaviour is one of the big barriers to getting epilepsy care, because behaviour is obviously a very fragile thing, and if a family's coping with something very complicated like that, they don't want that equilibrium to be disturbed. They're worried about our treatments making it worse. So one of the main jobs is to try and support through making changes for epilepsy, because in my experience it's not remotely always the case that the behaviour relates to epilepsy or its treatment. It might relate to the causation of the disability or other things, and because of that, if you go on the basis that you think a behaviour is caused by epilepsy or its treatment, you won't be changing the treatment very much, and that will the person's epilepsy will continue, and you're stuck in that dead end, which you don't want to be in, I think, where you can't have treatment options. So it's complicated, and obviously that's, I think, one of the things where being somebody who's been trained in learning disability psychiatry can be a little bit helpful. You've got some concept of who should be out there to support you, and recognising that it takes a village, and you need to have a lot of people around you who've got fantastic skills. And you in that 30 minutes can't remotely answer those questions, but you can support, as I say, hypothesis testing, and families going through that will be common. It is happening, and they will obviously need support, practical support and psychological support, because you want to try and get psychological support and behavioural support in, as young as the person can be, to stop it becoming entrenched. So it's very, very, very common to talk about a range of behaviours, and it's probably the big challenge, and not least because behaviours are quite a defined behaviour, but things like aggression, agitation are quite hard to quantify.
Yeah. I suppose a lot depends upon how the behaviour affects the people around the individual, right?
It does. I mean, obviously the patient is the patient, so we have to do, and that's obviously, and then that's why you have to become experienced at describing the behaviour, because you want to make sure that it's about what it's doing to the person, because if it's a care provision, we should be able to support those carers, or have enough carers or enough well-trained carers to cope with any behaviour, and that's when you come into sort of psychiatric drugs, which is not something I tend to get involved with, in terms of, I don't get involved in the treatment of behaviour with psychiatric drugs really, apart from when they make the epilepsy worse.
Right.
I mean, they do. Well, antipsychotics can certainly make the epilepsy worse, but that's when you've got psychiatric teams. So the general learning disability psychiatric team. So I work in a team, and I've got two fantastic colleagues who can monitor that element of it, and I monitor the epilepsy bit, and we know when we need to talk to each other to try and work out what's going on.
So you juggle the balls together, and that's another example actually of stuff that goes on behind the scenes that families rarely see, is that you guys are actually talking to each other. So we certainly are. I wouldn't say it always happens, but they should happen, because it's a special skill is sorting out those medications and trying to get them right, and it may not be the best use of my time to put my time into that, and when they can do that and I can do more epilepsy or whatever, and that's the team, isn't it? And the nurses, will be having a huge role in that as well. Would you say the future is looking better or less bleak than it has done in the past for people, for the people that we've been talking about?
Yeah, I think we should be positive. Yes, definitely. I think there are. Remember, it's only in 1990 I went to work in an institution, and now apart from there are small hospitals for people with behaviour disorder and autism and stuff, which are under increasing scrutiny to make sure they are delivering the proper quality of care. But institutions are hopefully not existent, or very, very rarely existent. So we now know that we can cope with pretty much any sort of epilepsy in the community. So epilepsy has not restricted people from living an integrated life. Other things might restrict, like availability of appropriate housing and funding and that sort of thing, but epilepsy shouldn't. So, and then on top of that, I think the world of epilepsy looks at intellectual disability in a different way now. Personally, I don't think it was very high up the agenda when I first tried to shout about it. Well, it wasn't very happy. Certainly in adult care, paediatrics has always seen so many people with disability that it's been the norm in paediatrics, but in adult care it certainly hasn't been, partly because people were partly hidden away in hospitals. So there's better inclusion, and then the treatments are changing. So there's specific treatments, specific genetic conditions. There's an interest in people with these complex conditions, which will, have a broader effect on everybody. The charities are fantastic and, are doing great things, and, communication is different. So I think the future is positive. Unfortunately, it's dragged down by, regular scandals, I guess, where reviews come out of cases which have been clearly not what you'd want in terms of quality of care. So you can get, I've always thought in Britain, you can get the best world-class care you could ever imagine, but you still got a chance of not quite getting that or worse. So the big issue is the working at the political side and the quality side, and the making sure you don't fall in between the gaps. And this population is always, it's the least able to speak for itself by definition, and therefore does fall between the gaps and can be given a raw deal. But at least now we can communicate that, and there's laws to protect it, and we've moved on an awful lot. So I would be positive, and there are loads of great people, loads of great young people, and the neurologists I deal with are incredibly positive about people with disability. And the medical students I used to deal with were fantastic about people with disability. They would often come and do projects with us and things. So I think, that side of it is fantastic. It's really positive. So we should be positive, but we should keep on fighting.
Fighting for greater investment, more equal distribution of funds for who needs support.
Knowledge and, application of knowledge. People shouldn't be allowed to meet people who don't know about the topic. They shouldn't. They should always expect a standard. I mean, there's to err is human, and people will err, but people should expect a standard and know they can get a standard. Someone should be able to see a specialist if they've got a severe condition. It's not imaginable in any other condition that you could have a severe lifelong chronic condition and maybe not be able to see a specialist somewhere, because it doesn't have to be in your own area. Most families are more than prepared to drive for a long period of time to see people if they have to.
Shouldn't need to, but exactly. It should be there.
So, that's part of the battle, and that's what the charities, SUDEP Action, and Epilepsy Action, the rest of the charities, they work extremely hard to get some political say in this. But we're all, obviously in the world of politics is more complicated, and as I told you before we started, I'm definitely not a politician. But epilepsy is one of the more common conditions, and certainly is funded and supported below its weight in terms of what finance does. Working in the psychiatric field, we mentioned a little bit about the stigma in terms of people, the connection between epilepsy and psychiatric conditions historically. I don't think that's the case now, I hope. But I think that stigma maybe still, pervades elsewhere in terms of epilepsy. Personally, I think it pervades in terms of sometimes people take a very simplistic approach to the knowledge you need to know to manage epilepsy. And, I think it is a very complicated topic with an awful lot of knowledge about it. It doesn't mean you're special to do it, just that there's an awful lot to learn. And some people sometimes, I think sometimes it's simplified.
Yeah, it's just a load of seizures, and if you can take drugs that stop those seizures, all done.
Yeah, and sometimes simple messages about the drugs that they're just all bad if you have more, which isn't remotely the case. Some people need more to get better, and some need less, and suddenly, so the simplification, I don't think you'd get it in some other difficult conditions. But the messages and the knowledge is communicated. You're doing it now. The knowledge is communicated so much more than it was. So that's why I think I am genuinely pretty positive, which is unusual for me. So that's quite good.
Well, thank you so much for joining us. Honestly, Mike, this has been great. I've been waiting ages for you. So thank you so much. And everybody, if you want to learn more about Mike, there are links below this recording.
Bye.